Life without health is like a river without water. But health is not just what we eat, it is also about what we think. On a finer note, good health is an outward expression of our inner harmony, which most of the time comes from peace in the mind, heart, and soul. Welcome, ladies and gentlemen, to Dr. Tapaswini's Corner. That's me. Today's discussion will be on breast cancers in young women. And to discuss the various pertinent issues on this subject, we have with us Dr. Bhawna Sirohi. You are a leading medical oncologist at the Apollo Proton Cancer Center, Chennai, India, with special interest in GI and breast cancers. Trained at the Tata Memorial Centre, Mumbai, and at the Royal Marsden NHS Foundation Trust, London, you've worked with various premier cancer centres globally. You are the Secretary of EBMT, European Group for Blood and Marrow Transplant, Nuclear Accident Committee, and also the founder-president of New India Cancer Charity Initiative, which has made targeted efforts towards screening common cancers in rural India. In appreciation of your contribution to the field of oncology, you've been awarded the Royal Marsden Award for Excellence in 2000, TMC Women's Cancer Initiative Award 2011, LBF Visionary Award for Excellence in 2011, Adi Abadi Women Achievers Award 2014, the Bharat's Heroes Award for Education 2018, to name a few. Welcome, Dr. Bhavna. It's indeed an honor to have you today.
Thank you, Dr. Tapaswini. It's such a privilege to be on your program.
So, we often say that age is a number, and a person is as young as he feels. But we do realize that this beautiful human machinery does wither with age. So how do we scientifically define this word young?
Over the years, we have come to a consensus that ladies who are less than 40 years of age would be classified as young women with breast cancer. And I think WHO says young means anybody less than 24. Oh. So, but for our treatment purposes, we classify as ladies who are less than 40 years of age.
Mm-hmm. So how does the statistics read with respect to young women with breast cancer?
Globally, if you see 4 to 5% of ladies with breast cancer would be young. Mm-hmm. But in India, because of our younger population matrix, majority of our population, I would say 60% is less than 50 years of age. Okay. So we have a larger number or a larger proportion of patients with breast cancer who are younger, which would be, I think, about 25 to 30% of our patients, which is a staggering number.
Right. So what do we feel? Is this incidence rising if you look at the world and our Indian statistics?
So yes, the incidence of breast cancer is rising, not just in India, but globally as well. Mm-hmm. Globally, I think 2 decades ago, we used to say the incidence of breast cancer is 1 in 8, 1 in 10. And mm-hmm. now that has moved on to 1 in 4 and 1 in 5. Okay. But in India, rural India, it's about 1 in 60 women will develop breast cancer. And in urban or semi-urban India, it's about 1 in 25 to 1 in 35 ladies will develop breast cancer. And this incidence is rising, according to some statistics, by 2% every year.
Oh, when we look at your figures of urban and rural, we realize that urbanization has brought in a lot of bag of diseases. So what is the major causative factors for breast cancer?
The population is rising in India, and we have not been able to control that. And the younger population matrix means more younger women with breast cancer. Also, there has been a transition in cancer, as you rightly said, the infection-related cancers like cervical cancer, or the stomach cancer, which are related to HPV virus and the Helicobacter pylori, are going down.
Okay.
But the lifestyle related cancers like breast cancer and colon cancer are rising in the cities. Also, there has been a reduction from competing causes like tuberculosis and malaria. So the focus has also shifted more to cancer. There is a huge shift and change in our social and cultural practices. Higher education means, more office work, later marriages, less
Right.
likelihood or a shorter duration of
Mm-hmm.
breastfeeding, sedentary lifestyle, use of alcohol, tobacco, postponing childbirth. So all of these are huge, major lifestyle factors which contribute towards it. In villages, the new patients with breast cancer is less because I feel that ladies are more active, they are working in the fields, they are slim, they are not overweight. Most of the ladies, when I go to a village for breast cancer screening, they weigh about 40 to 50 kilos. But it's, completely the opposite in the urban sector. They are having kids on time. They are breastfeeding because the risk of infection is less to the kids. The diet is organic completely because they eat what they grow. There is no processed food that is used. So I think
Okay.
these are the major factors
Mm-hmm.
which are causing cancer.
Now, if we look at the biology, breast cancer in a young woman and a breast cancer in an elderly woman, is it different?
Biology is different, and also I
Mhm.
always say ABC, the anatomy is different as well. So when most of the ladies I would see in my clinic who are younger, they are diagnosed at later stages, more
Okay.
advanced stages. That means the tumors are larger, and also they have more chances of lymph node positivity. As
Mm-hmm.
far as the biology is concerned, they are more likely to have what we call triple negative breast cancer, which
Okay.
does not express any of the receptors, or HER2 positive breast cancer, which is slightly more aggressive and fast growing. And
Hmm.
also, the way it's different from older women is the challenges are different when we treat younger women with the breast cancer, issues relating to sexuality, fertility, pregnancy. And the D is the diagnosis is difficult. Due to
Okay.
dense breasts in younger women, there
Hmm.
is a delay in diagnosis of approximately 3 to 4 months, not just in India, but in globally as well. And also,
Okay.
the last thing that is different is in younger women, they are more likely to have a genetic basis compared to older women.
Right. So let's talk a little bit about the genetic. How is this something related with young women having breast cancers?
About less than 5% of
Mhm.
ladies with breast cancer have hereditary breast cancer. So that
Right.
proportion is higher in younger women. It could be as high as 10%. And some studies in India have shown that it could be as high as 30%. So,
Okay.
younger ladies are likely to have an inherited breast cancer. So we recommend testing with the BRCA gene, BRCA1 gene and BRCA2 gene in all women who are less than 40 years of age. And
Okay.
the two main genes are BRCA1 and BRCA2, which you can pass on to the next generation in about 50% of the time. And in fact, it came into highlight with the Angelina Jolie story, because
Right.
you can do certain things to mitigate against those risks.
Okay. So if we look at the screening and imaging of these patients, is it different when we look at the elders?
So, women more than 50 years of age in
Right.
countries with the, universal health coverage, they recommend annual mammograms. And
Hmm.
in fact, we've always debated for women less than 40, they can have mammograms annually or every 2 years. But there is no screening method which has been validated in clinical trials for women
Okay.
less than 40 years of age. And I think
Hmm.
that is the reason why the presentation is late, advanced with larger tumors, because the breasts are dense, mammogram would
Yes.
not be the right test. If you carry the breast cancer gene, then we recommend having an MRI of the breast. But otherwise, I think the government of India also started an initiative where they recommend clinical breast exams starting from the age of 30 years every 2 years, which can be done at a community health center in the villages.
If you look at breast cancer during pregnancy, Is it difficult to recognize?
Yes, because of so many dynamic changes that can happen during pregnancy. The breasts are larger, they can be lumpier, they are denser as well. So it is difficult to recognize. And most ladies who are diagnosed with breast cancer during pregnancy are also diagnosed late. So I feel that breast exam should be an integral part of pre and postnatal care.
Okay.
So one attributes any changes to pregnancy or lactation and sometimes ignores the clear warning signs of breast cancer. So I
Okay.
agree that it is difficult to diagnose. Yes.
Right. So, looking at life, is it true that it's really difficult for a young woman with breast cancer to cope up? And so, what are the issues that we should discuss before we initiate any sort of a treatment on these patients?
So I think that's a great question. For young women with breast cancer, when they are diagnosed, they are at a stage in their life when they are either starting a married life or they are starting their careers. So they are at a very crucial point in their lives. And to suddenly be told, that you have to put your life on hold for 6 months because you have to focus on the breast cancer treatment. So a
Mm-hmm.
lot of psychological support is very, very important. So that is paramount. Then on top of that, we bring in genetics. So that itself is a discussion to be told that, you may have a genetic basis to cancer. That means that, we may have to consider or think about or talk about removal of both the breasts, which we
Mm-hmm.
call risk reducing mastectomy.
Right.
Most of these ladies will need chemotherapy. So hair loss, body image, having to think about the possibility of undergoing breast conserving surgery or even a removal of the breast mastectomy with or without reconstruction. I mean, these are major life decisions that they are having to take. And, some of our ladies are in their 20s. They've not been married. One of the other issues that we have to talk about is before we start treatment is fertility.
Right.
And we are married, we can talk about embryo cryopreservation. We can take the husband's sperm and the patient's eggs. There is no urgency to start treatment, I feel. To cure the cancer, and then 4 years later, she realizes that she cannot have kids is something, which you don't want to do. So it's
Right.
always better to delay the treatment by 2-3 weeks so that she has the time to either undergo egg harvesting or ovarian tissue biopsy or embryo cryopreservation before she embarks on the chemotherapy pathway.
Okay.
So I think all of these dynamics have to be discussed. Genetic testing has to be discussed. I think if we discuss all of these right at the beginning, it's like 2-hour consultation the first time. And once if you address this, then the patient experience obviously is better. Also, the treatment compliance is better. And
Correct.
if the compliance is better, the outcomes are better.
So I think one message which should go is that these young women who have breast cancers can conceive. Now, if we look
Yes.
at the treatment of the two different age groups, the young and the old, how is it different?
The treatment per se, surgery, chemotherapy, drugs, the
Okay.
targeted treatment, they are not very different. The radiotherapy, the recommendations that I would give for a lady who's 70 years of age or 60 years of age and a lady who's 25 years of age is not going to be very different because the treatment depends upon the stage of the cancer, the grade, and also the receptor status. But the additional discussions with the young women would be about fertility. And the other thing which is different is, the conversation around the genetic testing. We do it in older ladies as well, but in older
Mhm.
ladies, we only do it in patients who are triple negative. But in
Okay.
younger women, less than 40 years, we do it in every patient. And because it then helps them make a decision whether they would like to undergo the removal of ovaries or they
Mhm.
would like to undergo a removal of both the breast, which we call risk reducing mastectomy, so that you remove the breast, which is the risk factor.
Okay. Tell us that has this changing lifestyle and women in top professionals, has our treatment in some way we have looked into these aspects of career women? Has it changed? Have we de-escalated our treatment profiles? What change have we made?
One of the first things I tell my patients when they come, young or old actually, that don't put your life on hold. So we will tailor our treatments around so I have treated principals, doctors, theater nurses, stockbrokers. They have not given up a single day's work. But I always say every patient is different.
Correct.
For some, it's a me time. You want to take some time off and just focus on yourself holistically. For some, it is their coping mechanism because, if they give up work and just procrastinate and think about the cancer and the treatment, it just puts them in a negative zone. And yes, over the years, we've become very good at treating breast cancer. Our 5-year survival is about 90% in the best of scenarios. And now what we want to do is see whether we can focus on quality of life and de-escalate treatment. Like in surgery, we are no longer removing all the lymph nodes. So the risk of lymphedema goes down. The chemotherapy in certain patients we can give for 3 months, not 6 months. The targeted treatment now, there is an amazing study done in UK where we can give it for 6 months rather than 1 year. The cosmesis is better. There are amazing oncoplastic work that is being done for, ladies to have a cosmesis where you don't know which breast has been operated on sometimes.
Right.
And in radiation, we have from 5 weeks of radiotherapy, we've gone down to 3 weeks. And in some patients now we give it only for 1 week based on certain clinical trials without actually compromising the outcomes of treatment.
Right. So we talked about surgery, radiation, chemotherapy, and hormonal therapy. But are all these therapies advocated to all the breast cancer patients, or does it depend upon the stage and the grade and various other tumor factors?
So I think the reason why we have become so good over the years with the survival improving is I think each of these modalities adds 2%, 3%, 5%. And from when I started training more than 2 decades ago, so 5-year survival has gone up from 60 to 70% to now 90%.
Wow.
And so we individualize the treatment, not all patients need chemotherapy. We can look deeper into the tumor and look at the genomic assays and say that, you do not need chemotherapy. You need only hormone therapy. And we look at the receptor status, the estrogen receptor, the HER2 receptor, and decide whether you need targeted therapy. The hormone therapy, whether you need it. The only change in hormone therapy has been that we used to give it for 5 years, but now we give it for 10 years.
Okay.
So I think that individualization happens. I think 9 out of 10 patients who are cured have surgery and radiotherapy. And then on top of that, you add in hormone therapy, targeted therapy.
Okay. So this hormonal therapy that we are talking about and the hormone receptors, I think a little bit we should have our listeners to get to understand what does it actually mean. When you say a woman is triple negative, what implication does it have on the prognosis, on our treatment?
Broadly speaking, hormone receptors are proteins that are located in the breast cells. And in women, estrogen and progesterone. So estrogen drives growth and progesterone actually leads to maturity and stabilization. So more of estrogen actually leads to the cancer transformation. So these are the proteins we look at when we look under the microscope on the breast cancer cells, whether they are overexpressed and how strongly they are overexpressed. So we have a grading system. So we look at the estrogen receptor, whether it's 100%, 50%, or 20%. A lady who's 100% estrogen receptor positive, she actually has a better overall outcome.
Okay.
And compared to any other another breast cancer, and estrogen receptor positive breast cancer is the most common breast cancer. And triple negative is when the estrogen receptor, progesterone receptor, and the HER2 receptor, which is the protein which is also overexpressed, they're all negative. And broadly speaking, the triple negative outcomes are 10% worse than estrogen receptor positive ladies with breast cancer.
Okay. So do we see a difference in the treatment outcomes of our patients in the two different age groups, the young and the old age group?
So if you match them tumor type, stage-wise, size, the outcomes are not actually dramatically different if you match them to stage, size. But we know that the younger women have more of triple negative and HER2 positive and slightly more aggressive and higher stage cancers. So that's why the overall, if you look at it, the outcomes appear worse in younger women with breast cancer.
Okay. So what are the long-term side effects that we should tell our patients, we should enlighten them with so that they can cope up with it?
I think the long-term side effects, most of them are treatment related, which we must counsel them about. And also we must counsel them about the red flags, what I call is red flags, to look for recurrence signs. If they develop a new lump, or if they've had removal of the breast, if there are new nodules, or if there is itchiness also, which is not getting better in the area. So all of these are signs of recurrence one should look for. Loss of appetite, they have got bone pain, which is getting worse, they have lost weight. So these are signs of recurrence. So there are issues relating to psychological impact of treatment, especially in breast cancer related to body image, lymphedema. Also, we have to counsel about the heart health. Some of the drugs that we give can cause heart problems 10 years later, 20 years later. Bone health is very important. So that's why I cannot stress enough the role of weight-bearing exercises. In fact, it shows that ladies who exercise, the risk of recurrence actually goes down by 25%. So there are enough studies to show that. Second cancers, again, they happen 10 years later or 20 years later. Because we become so good, so we are able to say that, some patients may develop second cancers as well. That's why we no longer recommend doing frequent scans, because scans itself give you extra radiation. So we only recommend in early breast cancer that, ladies should have a mammogram. They should not have a PET scan or a CT scan. It's not recommended anymore. Ultrasound, yes, if it is suspected or a recurrence is suspected, you have a scan. The other long-term side effects are menopausal symptoms, vaginal dryness, hot flushes. Most of our ladies gain at least 5 to 6 kilos of weight. So in our support group meetings, that is the most common issue that we discuss.
Okay. So, Dr. Bhawna, you've traveled a lot. You worked at centers, various premier institutes all over the world. Tell us, what are the challenges that we are facing in our cancer delivery system, India vis-a-vis countries abroad?
So I think there are some challenges which are common both to the West and us. And the key challenges that I will face in India are patient awareness. Mm-hmm. So I think patient awareness is something which is hugely lacking. Most of my ladies will come, they've had a lump for a year, but because it is painless, they would just not come. They've had a lump in the neck, they will just not come because it's painless. So I think patient awareness is something, and what you're doing is great because you are actually helping in create that. Access to care, from remote areas like from the Northeast traveling, the topography is difficult. Financial, we do not have universal health coverage. Everybody has to, yes, insurances are there, but the drugs are so expensive nowadays that most of our patients finish up their insurance within first few months of treatment. Huge disparities in cancer care, 5-year survival, which is 25% in one part of the country and 60% in another part of the country, which is very sad. As oncologists, we are very short of oncologists, trained oncologists, especially in remote villages. So the cultural issue in India that, we do not talk about cancer.
Correct.
And as far as in UK or in the West, I think the main challenges have been the wait list for surgeries, wait list for starting of chemotherapy. because there is a fantastic screening program, but then, so the numbers are high, but the resources are limited. The care is free, but the other logistics are there. And in both India and abroad, common challenges are overuse and misuse of, medical resources. And so that's why the Choosing Wisely initiative is very important, not doing unnecessary PET scans, giving a single fraction of radiation instead of 5 fractions or 10 fractions in palliative setting. So all of these things are common to all of us globally, I think.
Okay, lovely. But tell us, all said and done, treatment done, patient is doing fine. Do we still want our patients to be on a constant and a regular surveillance?
Yes, I think surveillance is very important because not only to pick signs of early recurrence, which may still be treated with a curative intent, okay, and also to make sure the patients are complying with the treatment. So a lot of our ladies I've seen, if you engage as far as hormone therapy is concerned, hormone therapy like tamoxifen, letrozole does have side effects. Mm-hmm. And sometimes, and we know that it leads to an overall survival benefit. That means the ladies will live longer if they continue on this treatment for a period of 10 years. Okay. And stopping it early or non-complying to it will actually hugely impact outcomes. So I think surveillance is important, not just for recurrence, but to manage the long-term effects of treatment, to detect the long-term effects of treatment, and again, treat with a curative intent.
Correct. There are a lot of breast cancer support groups, and you are so much involved with them. How does it work, and how useful are they for the other survivors?
So, I think this is what the patient said to me, someone else who has been through it gets it. You don't. And, which is true. And for a patient I'll just tell you, I treated a patient, one of my HER2 positive patients was going to start on the journey of, this 1 year of treatment, having a chemo port put in. And for her to meet another patient I had treated just 10 years ago, it gives her so much comfort to be able to talk to somebody who's been through the same journey and see her at the end of the tunnel. So I think it deals with fears of isolation, gives hope. And I think, it's not for everyone. I think each patient has to find for themselves a support group that they need. So I think it's each for their own. There's no one size that fits all.
So we're almost to the end of this program. Dr. Bhawna, what is that message that you would like to give to our listeners? Something regarding prevention and whatever you would love to share at the end of it.
We can prevent breast cancer. And yes, in about, I would say 5% we can't because it is genetic. But I always say it's the ABCs of cancer prevention. A is you avoid alcohol, avoid smoking, because these are risk factors. B is be breast aware. So, know what is normal for you. Understand your body. One of your breasts may be larger than the other, but that may be completely normal for you. But get it checked out at least once, by a professional, any professional with a clinical breast exam. Breastfeed, be for breastfeed as well. And I also should say be vaccinated as well, because there are 2 cancers you can prevent, cervical and liver cancer. C is for calm, have some calm in your life, some form of yoga, meditation. D is for diet, food matters. Have a balanced diet, which is, full of fruits, vegetables, and something that is grown locally. D is diet, E is exercise. WHO recommends 30 minutes daily. You must do that. It prevents breast cancer. F is know your family history. And S is for screening. Go for screening, when you're eligible. I think that would be my short message.
Wonderful message, Dr. Bhawna. And it was a pleasure talking to you. Thanks a lot, Dr. Bhawna. It was indeed an honor to have you today on this show.